I think in the interest of time, we'll be starting this session. My name is Adrian from Singapore. I'm privileged to have Dr. Guan with me as the co-chair for this session. This session is special because it is the first time that we have a live case demonstration from Sapporo Heart Center, Japan. And we are privileged today to have Drs. KASHIMA as well as Dr. SUGIE to demonstrate complex rotablation. Now, rotablation is a very important technique in intervention, and all of us are familiar with Dr. Kashima's expertise in this, and we definitely look forward to learning from him. So before we start off the presentation, I'd like to just introduce the panelists on board. We have with us Dr. Alan Chan and Dr. Chan Kam-Tim from Hong Kong, Dr. Praveen Chandra, Dr. Ji-Hoon Kang. Dr. Wiraj is, I think, not around, but we have, oh yes, Dr. Wiraj, great, please come on board. And we have also Dr. Kyono, Dr. Dijan Milasinovic, as well as Dr. Sim Hui Hian. Yes, so without further ado, let's just move over to Sapporo Heart Center, and we would have Dr. Kashima and Dr. SUGIE introduce the case to us.
Okay, thank you so much. Good morning, Adrian. Can you hear me?
Very well.
Okay. At first, and so it's a very honor to become live satellite in our hospital. So thank you for KK Sensei, Adrian Sensei, and Singapore Live staff. So this is the second operator, SUGIE Sensei. And this is, Kuramitsu Sensei, very famous IBAS analyst. And this is my boss, and Fujita Sensei. This is a president of our hospital. So anyway, I show you today's case. So Matsuno Sensei, please introduce the case.
Thank you for introducing me.
Case introduction, please.
Sorry. So thank you very much for participating in today's live demonstration. Now, we will now begin our case presentation. So the patient is 70 years old male, and diagnosis is CCS2 effort angina. And the coronary angiography shows double vessel disease in the left coronary artery. And prior PCI was none. And his cardiac function and renal function are almost normal. And today's target lesion is bifurcation lesion with severe calcification in LAD. And this is coronary CT angiography. And this reveals severe calcification from proximal to mid-LAD like this. And as you can see, a concentric calcified lesion is observed proximal to the LAD. And while a severe calcified lesion is identified contralateral to the diagonal branch. And this is coronary angiography, and these are caudal view. And left circumflex segment 13 has 99% stenosis. And these are cranial view. And LAD segment 6, segment 7, and first diagonal branch have 90% stenosis. And these are target lesions of this session. And we have already performed PCI on left circumflex segment 13. And we put a DAS at mid-LCX and followed by a 3.0 mm balloon dilatation. And the procedure was completed successfully. So, PCI strategy and learning objective are as follows. Target lesion is proximal LD bifurcation with severe calcification. And in this case, the right femoral artery approach was utilized, and 8 French FCL was chosen for the guiding catheter. And we plan to implement the rotor cut strategy. The initial bar size will be 2.0 millimeter, followed by 2.25 millimeter to the proximal region. And the final device will be determined based on the IVUS findings after rotational atherectomy, with plans for the either left main to LED crossover stenting or proximal LED stenting. If necessary, we will perform POT and final KBI and report as well. Then, a learning objective is how to optimize calcified bifurcation PCI using rotor cut strategy. That's all my presentation. Thank you very much for kind attention.
Okay, thank you so much, Matsuno Sensei. So, Adrian Sensei, is it better to share today's angio and IVUS?
Yes, yes.
Okay. So this is today's angiogram. So epicranial view like this, and so next, this is the RL cranial view. I think this is a good image to rotablated and distal part. And the next, this is a LL cranial view. We cannot find anymore. And this is spider view. Spider view is very useful to rotablated and proximal part, and selecting the diagonal branch. So this is RL caudal view. That's all. Then Kurami Sensei, please explain today's IVUS image.
Okay, thank you very much, Kashima Sensei. So Adrian, can you see the IVUS on your screen?
Yes, we can see very well.
Oh, okay, so I want to review the IVUS so quickly. So this is IVUS pullback from distal LED, and so now septal is coming from 6 o'clock, and we can see the superficial calcium. This is a diagonal branch, and so we can see the very diffuse region. So actually there are several key points, so we should assess before procedure. So the distal reference vessel size 3.5, and the first point is the wire bias. So this is a major septal branch, and so this side, the IVUS location, so attach the normal size. That's why we should take care of this part. But other part, the wire bias looks very nice. And second point is the bifurcation side. I mean the risk of the side branch occlusion. So this is a diagonal branch. So we can see the superficial calcium as the opposite side of the diagonal branch. And also, looking at this IVUS finding, I think the side branch run parallel to the main branch. So it means the coronary shift is likely to occur. And the last part is the discrepancy is the vessel diameters at proximal and the distal reference side. So the vessel diameter distal 3.5, but left main 5.0. So this is a key point of this IVUS finding. Thank you very much.
Thank you very much.
Okay. Yeah. Adrian, please discuss something.
So I think the IVUS show very nicely the calcification. It doesn't appear to be concentric. And do you think that you could get away with just like simple cutting balloon strategy?
Yes, of course. And so some cases, and so I think cutting balloon and IBL can work well. However, nobody knows because IVUS, OCT, both items cannot show us hardness itself. Thickness is not so hardness always because density and material are much different for each calcification. So I think in this case is required rotablation. So because this case has large diagonal branch and also osseous diagonal branch has stenosis. So if we avoid branch occlusion, of course we need a volume reduction on the opposite side of the branch calcification, opposite side of the branch. So my strategy first is rotablation.
So this is Hyunchul Kwon from Samsung Medical Center, Korea. And I agree with Dr. Low about the indication of rotablation. So usually I only use rotablation for encircling calcium But I have noticed that the bone-to-artery ratio in your planning for rotablation is very high. You're considering use 2.0 or 2.15, then maybe the beneficial for the stent expansion. As you know, in the recent imaging trial, Renovate Complex, or a lot of trials show that the stent expansion is the most important predictor in that, for the outcome in that trial. So I agree with you with using the higher bone-to-artery ratio near to a 0.5. But in this case, rotablation not helpful to facilitate the procedure, but I believe that it facilitates the stent expansion. Of course, I'm not sure it is related to a clinical outcome in the end.
Okay, Gon-sensei, of course, I agree and as a part of your suggestion. So, however, so recently, so our younger colleague and so Yui-sensei presented about some data. So of course, and so acute lumen gain is and so enough, important, so in severe calcified region. But only that 1 year MACE is increasing, so 20% more. However, if we can get, so not only the acute lumen gain, but also symmetrically index 0.7 of DES, 1 year MACE is and so less than 5%, only the 4% around. So much 5 times different. So our strategy is and so endpoint is that lumen gain, enough lumen gain, of course, and a good symmetrically index of stent. So rotablation is setting like this.
Well, this is Chen from Hong Kong. Just a couple quick points. Last time this year, we don't have any recommendation, only class 2 recommendation for the use of IVUS. Well, you know, after the ESC meeting just in August last year, we have already got a class 1A recommendation for the role of intracoronary imaging for complex lesions, especially left main, true bifurcation, and long diffuse disease. So I think Dr. Kashima excellently demonstrated nowadays. I think we don't have any excuse of not using intracoronary imaging, all right, for these sort of complex cases. The second question I would like to ask Dr. Kojima concerning the luminal gain. I think orbital atherectomy device is also available in Japan, all right? With the use of OAS, you can create a much bigger orbital gain, diameters by the use of OAS, using a slow beat and then followed up by the high speed. What's the choice of rotablator as compared to OAS in this particular case? Thank you.
Yes, very nice. Question. Because we have two volume reduction device. Of course, you know the OAS. Another one is OAS. However, I sometimes show my presentation. So based on the physics, OAS has rotablator has 4 to 5 times ablation performance of the OAS. So you know this case is so difficult to ablate it and so relatively distal part like this. So I think and the OAS cannot ablate it enough this region. And of course, you know, OAS can work well and so less than 1 point cannot work well and can work well as the same as and so 1.75 bar equivalent. So this case is and so required more than 2 bar. So I don't choose OAS. So actually I choose and 2 bar as the first rotablation like this.
Dr. Kashima, this is Yoshimachi speaking. So I'm agree with using the OS use because of I'm afraid of the distal embolization with big bar, and if you use maybe 2.0 millimeter bar or 2.25 millimeter bar, it needs the 8 French guiding catheter, so it's a high risk of the bleeding. So actually, I always use the distal radial approach with using the 5 French or 6 French guiding catheter. So it's rather difficult to use the 1.75 bar or more. So just using the modification and
cutting burn using, it may be not so difficult with using the
どうしようぞ。
such high risk
I was-
rotablation. What do you think about that? Of course, I know you are the specialist of the rotablation, and you can make the very big round shape of the stent. What do you think about that?
I don't
yes.
think,
So go ahead.
yeah, I don't think there is any extra advantage of using orbital over here, because what we see is that when we go to higher speed, like when we go to higher size, then the chance of having
Okay, put it
a
back.
slow flow is higher compared to a 1.25 speed. So basically, rotablation in this case, I mean, he is using a 2 millimeter burr, which is very good, but some people will do it, it can be done differently. And I might choose to just use a 1.5 burr followed by a cutting balloon or a IVL, depending upon what is available and what is possible. But these are the 2-3 possibilities which we can do, and then of course put a stent or whatever. Yeah.
おうここね。OK。これぐらいね。はい、いいよ。はい、じゃあ225。
What was the size of a burr in less burr size?
Oh,
So, Adrian, so can I review this IBUS ProBuck finding?
Yes, please review the IVUS
Okay.
findings. Can we just confirm that this was a 2 millimeter burr that you just used?
Yes, so actually this is a IBUS ProBuck after 2.0 burr. And so let's review this IBUS finding so quickly. So this is a different side. And going forward, so this is a septal. And beyond the septal point, so actually the, どこだっけな? Sorry.
Yeah.
So this is a septal and the more proximal. So
19万。
we can see some vessel injury
いいよ。
here. But
Hi,
the
Diana.
calcification is aberrate. This is a diagonal, so that we can see the severe calcification at the opposite side of diagonal branch. So this part looks aberrated, but the severe calcification is still
は
there.
い、ダイナグライダー。
And more proximal,
なんか圧が足らんよ、これ。もう逆決しとるよ。
Actually,
So this
I
is circumference?
always wonder that for the eccentric classification,
いや、だから足りてないから
rotablation
して、
have
とりあえず。
how
Ah,
much
yeah.
about the efficacy, but I found some improvement
Spider.
in interlumen at the site of the diagonal bifurcation. It's good sign.
yes.
But is
Oh,
it
sure.
good enough? I'm not sure.
So personally, I think it's not good enough. So because we can see the
俺が上
severe
げてんの。
calcification and the wire bias looks nice. And as already mentioned, the risk of side branch occlusion in this case looks higher. So because we can see the severe calcification at the opposite side of the diagonal branch, and also the side branch run the parallel to main branch. So that's why KASHIMA sensei aggressively performed rotablator. So just for the proximal part.
So to be sure, you're using the 2.0 burr again.
I think it's 225.
225.
2 to 5. Wow, really?
鹿島先生、鹿島先生、
はい。
This is Kyono speaking. こんにちは。先生、what types of wire do you use now? The floppy or
This is
support?
always floppy.
Okay, thank you. And you are doing in a 225, right?
Yes.
Yes.
Kyono sensei,
Just
225.
proximal portion, right?
Yes, you're right.
Yes, of course. So until the diagonal branch.
Okay, thank you.
Yeah, IBUS.
Kashima Sensei, if you don't mind, I think the panel as well as the audience are just surprised that you move very quickly with from 2.0 to 2.25. So you started immediately with a 2 millimeter burr. You didn't start with a smaller size burr, and you just went straight from a 2 to a 2.25.
Yes, before the IBUS pullback. Yes, before the procedure, without IBUS image, I think 1.75 is better as a first rotablation bar size. However, after the IBUS imaging, so of course we needed much more larger bar because I sometimes show you And so BA ratio, BAT ratio, 0.5 less is insufficient always. So if we make we make a rotablation, volume reduction, if possible, we have to set in more than 0.5 always. So today I choose in the 2 over and so 2.25 for the proximal side. パンフレーションとかないよね、手前も。いいよ。ディスタル分かったら。And so some commentator ask me risk of the rotablation with larger bar. So I don't think so because I always make same rotablation in any situation. So set 0.5 BA ratio more as a bar size, and of course rotational speed, and so more than 80 atmosphere as a fast. And so then gently manipulation always, because we need to support differential cutting mechanism and follow the bar vector as same as D-star vessel vector. So if you can follow these theory manner, you don't have to make coronary perforation. Of course, sometimes injury happen. Today's case is, of course, in the distal part, some injury happened. But in the soul, no perforation. So it's my rule. So you can do that as same as me.
Dr. Kashima,
Yeah.
could you tell me the relationship of the speed and the bar size? What do you think about that? You said
Yes.
This is maximum speed?
No, it's a good question. So you know, basics based on the physics, of course, and so larger bar always makes a good rotablation performance compared with a small bar when we set the same rotational speed. So if you choose more than 2 over, you don't need more than 200,000, almost always. And of course, if you set less than 1.75 bar, sometimes you need 200 more, because surface speed is much different. So rotablation performance is getting better on the larger bar.
What do you think about the low speed polishing after high speed polishing?
Yes, good comment. Thank you so much. So slow speed rotablation is original of our technique. So of course, more than 10 years ago, we recommended low speed rotablation about 10,000 and 100,000 and 120,000. However, we find some injury like OAS, so we stopped that procedure. However, currently, of course, we continue to use more than 140 to the 160 slow speed rotablation to get extra acute gain. Of course, it's one option. However, at that time, rotablation bar makes an orbital movement like OAS, so differential cutting performance getting lower. So if you find a risky point, of course, you don't use slow speed rotablation.
Okay, I think there are two, purpose to use the rotablator. One is plaque modification to achieve a good stent expansion, and the other is debulking. So Kashima sensei, today you are relatively, get a debulking effect rather than plaque compliance change. Is it correct?
Yes, of course. Volume reduction means, of course, reduce calcification mass. And of course, compliance is much changer. It's an important point. Okay. Of course, cracking, additional cracking makes much more, getting good compliance of the vessel. But sometimes not enough. So I choose volume reduction and cracking technique.
Thank you. And the other concern of this case is that you have a big diagonal branch, which is prone to be
さっきダイアグノーシス上げる。
compromised after
2
center
ミリカッティ
implantation.
ング。
So that's why
How do you
I think
think?
you try to use the bigger burr to reduce the calcification of the opposite side of the diagonal branch. So, and
Yes.
do you have any calcification in the proximal of the diagonal branch? Actually, I didn't get the IVUS image
違う、
from
ビ
the
ューが違
diagonal.
う。sorry, one more please. Sorry.
So Adrian, so
Okay, go ahead.
so-
Kashima said, do
Can
you
you
have
see- yeah.
calcification of the diagonal branch, proximal portion of the diagonal branch?
yes,
本館から。
this is a prox.
いいよ、
can you
即
see
死
the IBUS finding
即死ちょ
now?
うだい。どっちがどっち
Anyway, so we can see the calcification. So around the left main bifurcation site. So however, not so severe.
これ本館ね。
Can you show us the angiography after rotablation? We only see the IVUS image. We like to see the angiography.
Okay.
Okay, please show the IVUS image.
No. Angiogram.
アンジオグラムのまだ今やってるから。
So actually, I have not yet taken the picture after rotablator 225. So now Kashima Sensei performed the side branch dilatation with 2O,
20224。あ、ちょっと待って。
2O cutting balloon.
カッティングバルーン 2O カッティングバルーン and 3O カッティングバルーン 4 kissing balloon technique. So this is an after rotablation. Of course, little bit and so spasm happen, but in the so. どっちがどっちこれが 3?
Yes, maybe I have a question to Dr. Kishima or to the panel. As a follow-up question, for those really two severely calcified bifurcation lesions that got high risk of side branch occlusion, we can perform sequential rotablation. We need to pull out the guide wire in the side branch, otherwise we cut the guide wire. So I think there's a consensus statement from SCAI probably last year that for selected cases, some people actually put in 2 guide wires, one in the main branch, one in the bifurcation, and then they use a microcatheter to protect the side branch guide wire or guide extension catheter, and then use the rotablation to rotablate the main trunk, the main branch, while keeping the guide wire and the microcatheter in the side branch, all right? Of course, sometimes you need to move the microcatheters, change the position after each rotablation, trying to avoid the persistent ablation of that microcatheters. I never tried that, all right? But I want to ask any panelists or Dr. Kashima, we really want to protect the side branch, which is a big side branch, very high chance of occlusion during rotablation. Is there any other genius way of doing that? Or the SAI, actually, in a consensus statement, they recommend that, but I never tried that. I'm not sure any panelists have tried that before.
High deflation.
Yeah. Maybe if I can comment, I mean, this is a wonderful case that demonstrates to us perhaps even a 2 bifurcations PCI, because there is an ostial LAD lesion which on IVUS looks very close to the left main. So this may be, 2 bifurcations in one. To get back to your question about preparing the calcified bifurcations, I think this was a beautiful demonstration how IVUS can help. We could see that most of the calcifications here were on the lateral wall, away from the ostium of the diagonal, and the ostium of the diagonal itself seemed to be without serious disease. Now the question is, what to do if there is a lot of disease at the ostium of the diagonal? Will then the rotational atherectomy cause any damage to the diagonal? So that's the first question. And I think in that case, there might be the option that you mentioned with the microcatheter. There is another option, which should be mentioned, I think, in this regard, and that is when the tight calcified lesion is a bit below the branching point. In that case, in my humble opinion, what you could do is pass the extension catheter over the branching point and then go with the rotational atherectomy through the extension catheter. On that way, you're not touching the bifurcation
Inversion.
point, and you're not jeopardizing the side branch. So that, I think, is another option, but you need to realize what the plaque distribution is and where the most calcified plaque that you want to modify is located. If it's below the branching point, then I think the extension catheter can be used to deliver the rotational atherectomy through it.
So if we have ostial diagonal lesion or long plaque which is calcified in the diagonal, then I think combining strategies is also a good idea. That you do a rotablation to the main vessel and then put a second wire, and then you can use either a cutting balloon or a IVL or any of these scoring balloons to treat the diagonal, and then of course finish with whatever strategy you want to do.
KASHIMA, it's Alan from Hong Kong. So I think it's really nice case showing rapidly upsizing the burr in tackling with this very violation is a big one. Imaging did really help. Otherwise, I think most of us will not dare to put our 2.0 burr right at the beginning. Right, but after seeing the imaging, we see the size of the vessel is big. So 2.0, I think, is pretty much the right size if you're talking about the ratio. How about after atherectomy? You see the imaging, and then when will you consider, for example, cutting balloon or using IVL? Because appearing from all the imaging, angiogram, IFS, there's a lot of still calcification behind.
Sorry, during the procedure, I cannot catch a lot of questions. So after my comment, maybe Kuramitsu sensei explained that. But if you make only cracking technique, you cannot make a good expansion because this is a 40 atmosphere cutting balloon. But you can see that insufficient balloon inflation, dilatation, even after the 2.0 and 2.25 rotablation. So if without rotablation, nobody can get good expansion with cracking of the cutting balloon. After 20 atmosphere with volume reduction with 2.25 rotablation, then can get this dilatation. Everybody easily understand. Without volume reduction, nobody can get good expansion in this case. Okay, please.
Okay, so due to the limited time and this is Shoichi speaking, and instead of the Kashima sensei. So I'm not sure who talked to the side branch protection technique, but honestly, our centers, we have never performed such kind of protection technique when performing the rotablators. And when we consider severe stenosis, with severe calcification at the side branch, of course we should perform rotablators if needed. So that is our style. So I'm sorry, I forgot there are some question from panelist or chairperson. If needed, please let me know.
So I think thanks very much. I think that's a very nice demonstration of what you have just shown. I think the question is when you have a major side branch, and the concern is how do you rotablate while protecting the side branch? Do you?
Okay. Thank you so much. So no need in the side branch protection during the rotablation, because rotablation doesn't have any mechanism to get in the side branch occlusion, because the rotablation effect is only ablated inside calcium. So if making if you get in the side branch occlusion during rotablation, it means that your rotablation is rough, because huge debris is happen. So its debris goes through to the side branch. Of course, sometimes you push strongly vessel wall. Then carrier shift happen by your strong pushing force. So if you make and so gently and so right rotabulation, nobody get in the so side branch occlusion during the rotabulation. It's basic, so it's so physics.
Yeah, I agree that the side branch compromise is very rare after the rotablation for the left main branch. Mostly, actually, without debulking, actually, in this bifurcation, the side branch compromise is also rare because we adjust the balloon pressure and size. The most commonly, frequently, we undersize the stent at the bifurcation. The end result is under expansion of the stent at the side bifurcation, not the side branch compromise. But usually this is not my practice, and I learned from Dr. Kashima that aggressive debulking, you may expand more aggressively at the point of bifurcation. But clinical implication, I'm not sure.
Sorry, now and so wire twisted, so 3 wire. Okay.
Too many wires actually, so.
Yeah, because the two main vessels are branch.
Risk is very, very low. Usually I use only 1 wire for this lesion.
Thank you. Inflation, please. Yes, of course. So it's a good option. But so I don't want to get the only 1% risk for the patient. So deflation. Okay. So I use that's strategy. But of course, twist is so severe, then I cannot get deliver the balloon. Of course, I removed the side branch wire. Inflation 14.
So what size of the balloon?
Yes, I already make 2O and 3O cutting balloon, 4 kVt. Both balloon is both balloon are cutting balloon. After that, this is a 3.5 for the proximal side. Of course, it's a cutting balloon. Because I want to make the cracking inflation 14. So I don't always use conventional balloon, deflation. Still indentation is there, inflation 14. 20. Okay, deflation. Okay, it's good. So after rotabulation with more than 0.5 BA ratio, always cutting balloon with high pressure can work well to make cracking inflation 14.
Yeah, you are doing a very aggressive lesion preparation. The rotablation 2.25 and the cutting balloon and up to 20 atmosphere. So we really like to see the stent expansion in this case. So you have 10 minutes to go, so please show us the stent expansion in this case.
IVAS, please, IVAS. Anyway, so I want to IVAS check. Checking an IVAS. Please wait a moment. で、じゃあ、3O のシナジーか ?3.5 か ?OK。インジャリー起こしてるとこも大丈夫ね。OK。3.5 広げていいのね。じゃあいいよ。はい、OK。じゃあ、プルバック。Yes, this is IVAS. OK. Please show the real-time IVAS image because time is remaining 10 minutes.
So actually, this is the IVAS after aggressive lesion preparation. So this is a septal branch, and we can see some this injury, but we can see the dissection. This is a diagonal branch, and we can see some crack before the diagonal branch. This is the left main.
いいね。
Okay, stop.
OK。はい、じゃあ3.5シナジー32かなんか。はい、ちょうだい。
Yeah, lesion is well prepared. And I'd like to mention that in the studies comparing the eccentric calcification, concentric calcification, the result was less favorable for eccentric calcification. The concentric, we have a lot of techniques, high pressure ballooning, cutting ballooning. The eccentric is very difficult to have a very circular, well expanded stent result afterwards. So this is a very aggressive preparation. I really like to see.
もうちょいか。いいよ。
What is the size of stent?
Inflation. This is 3.5 by 32 synergy stent.
Synergy.
Inflation 40. Yes, synergy stent. Yes, because of course I understand your opinion is Megatron for this case. Deflation.
Actually, synergy stent is that you have, balloon is a little bit compliant compared to other stents. So now I'm not using it for the calcified lesion.
Yeah, but of course I choose Megatron stent for the proximal. So why I choose synergy stent for this style? This is so easy because stent overlap point around the diagonal branch. So if Megatron stent and Megatron stent overlapping, then three ring and proximal 5 ring combined. So it's very confused, complex and structure there around the ostial diagonal branch. So sometimes diagonal branch occluded. So in this case, I choose synergy stent for distal proximal, Megatron for the proximal side.
Kashima-sensei, you're using the gel wire technique. How often do you use the gel balloon or modified gel balloon to protect the diagonal or the side branch?
Deflation. I have never used a gel balloon technique because I don't have any trouble compromise side branch. Because I always make a volume reduction to prevent side branch in the severe calcified region. So I don't have use gelled wire, gelled corrosion technique.
Please tell us the balloon pressure.
High deflation. This is 14 for the stenting, and after that 20 atmosphere.
20.
Yes. So, OK。はい、じゃあプロキシマルいくよ。さっきアイバスするか。じゃあいいわ。じゃああれちょうだい。プロキシマル3号の16。ちょっと待ってね、即死先抜くわ。じゃあこれダイヤゴや。見た？うん。はい、即死 OK ね。そっちが即死や。こっちか。これ違う。これダイヤゴ。こっち。OK、はい、抜いていいよ。はい。じゃあスパイダー。So this is a 3.5 and so 60 or 20, or I'm not sure. 60, sorry, 60, so Megatron stent. ごめん、もう一回、R クラニアルくれる？そうだ、そっちで見んと分からへんな。ストップ、ここでいいよ、ここでいいよ。Yes, I check and so this star overlap, this view, it's okay. はい、で、そのまま待って、ストップ、wait. And proximal, almost okay やな。Little bit pull out, pull back. ここでいいんじゃない？ Yes, looks good. Overlap is so minimum. High inflation, 468. Okay. 14, 20. これ 3.5 よね。24. Okay, deflation. Hi, okay. Only 14. Hi, okay, deflation.
Tachima-sensei here.
Hi.
We noticed that you usually go beyond the rated pressures on your stent deployment. Is that usual for you?
Sorry, one more please. 24.
Yeah.
Okay, deflation.
レイテッド超えて拡張するのがいつもそうなんですかって言って聞いてますけど。
Yes. Sorry. Thank you, 京野先生. Yes, I always use more than rated pressure because this is an unresolved region. It's severe calcification. If non-calcification region, of course, I always follow the rated pressure. But this is severe target. 手前広げる。ポット何ミリ？ いいよ。I want to put technique after that, and I want to check and IBUS to you. However, Kuramichi sensei advised to me, yes, so IBUS first, please. Okay, IBUS. オンにして。どうや。はい、OK, please put it back. Of course, and so proximal part in the so before the optimization. This is the distal. Okay, Kuramichi sensei, please.
Okay, this is the IBUS. So after stenting, and the stent is well expanded. So this is diagonal branch, maybe diagonal branch, and this is the proximal part. The stent position looks nice, and of course we need a post dilatation pot, so for the left main, and also proximal already.
Please stop the LED diagonal bifurcation. I would really like to see the.
Okay, sure.
Yes. So after this IBUS imaging, I don't like the so images about in the so middle of the LED. This part is a symmetrically indexed and less than 0.7. So after the proximal port, then I make a much more dilatation with high pressure for that region.
So, Dr. Guan, so can you see the IBUS?
Yes,
so
sure.
Actually, I will show you your interesting point. And we can see the diagonal branch at the 9 o'clock. This is the diagonal. And so this part looks like a very eccentric calcium at the beginning of the procedure. But, looking at the stent expansion, so looks so nice.
Right, yeah, very symmetric and circular.
Yes. So, however, looking at the more proximal part, we need a more post-dilatation. But anyway, looking at our interesting point, so the stent is well expanded, so symmetrically, so due to the aggressive, the KASHIMA sensei rotabrator style.
Okay, this is wonderful. The elliptical site in the proximal area, actually, both sides are too small, actually. 2.5,
yes.
2.5 is small. But we have to accept the result. But at the bifurcation, it's a perfect stent expansion, circular expansion. I love that.
Thank you very much.
Yes, so if I have so much more time, I want to make so slow speed rotablation for the proximal side with 2.25. Gang sensei said. So of course I agree that. However, so I'm sorry, today I cannot finish until the finishing time. So, but you can see the good dilatation of the main branch, and so for with and protecting the side branch like that.
Thank you very much, Kashima Sensei. I think we have to leave you now. I think despite you not completing a case, I think you have shown enough and you demonstrated very well your excellent skills again as usual on rotablation, and we have learned a lot from you. Thank you very much, Kashima Sensei, as well as SUGIE Sensei, and all the way at your Sapporo Heart Center. And we thank you for your time with us and a very educational session. Thank you, everyone.
Thank you so much. Adrian Sensei, I will arrive tomorrow morning there. Bye-bye. Thank you.